hope you are ready to start the session.
Yeah, everything is in praise.
Okay, I'll be presenting and letting people in at the same time.
Sure.
But for the sake of time, we'll just start. I hope I'm loud enough.
Yeah, I can hear you. I don't know about me.
Okay, so Joseph, today we have a case. I think it's going to be a bit long, so I'll try and be fast. But it's an interesting case and good for those who joined today because I believe we are going to learn a lot from Joseph. It's an interesting case and we have an interesting discussant. So looking forward to learning a lot from Joseph. So Joseph, today we have a 33 years old female with chest pain for 3 days.
Thank you very much. And as you said, it's going to be a long case. So, straight into the case. And chest pain is among the complaints that are very common in medical practice. And for complaints that are very common, everyone should have at least something that you think of immediately when you hear them, because it helps you like arrive at a diagnosis fast. And I think we have shared some my approach here about chest pain, and mine is first of all, chest pain is scary, so there are serious diagnoses that should be ruled out first. Like when you miss them, patients are going to die probably. So I have 8 diagnoses that you should rule out when you see a patient with chest pain before you proceed with anything. And I remember this by recalling them that they are um, 4 plus 2 plus 2. It's not like a 4-4-2 in football, but 4 plus 2 plus 2. And this means there are 4 cardiac causes, 2 respiratory causes, and 2 GI causes that can cause chest pain. So the 4 cardiac causes, this includes, as we all know, acute coronary syndrome. The second one is aortic dissection. Another one is Takotsubo cardiomyopathy, and the last is tamponade. Make sure that you rule this out. And then if you come to the respiratory system, you have 2 things. They both start with a T, and sorry, they both start with a P. So it's a pulmonary embolism and then pneumothorax. But lastly, you have GI causes, very serious, that can cause chest pain, which includes esophageal rupture. And before you get esophageal rupture, some patient might present with just esophageal impaction, which will later go into esophageal rupture. It's very bad because when they rupture, they get mediastinitis, very serious disease, they will die. So if I know maybe they don't have this, I go on and think of the approach depending on the layers of the chest. So if you think of the chest, you have the skin, subcutaneous tissue, muscles, bones, pleural space, pleura, lungs, the cardiac also it has pericardium, myocardium, the valves. Everything of that can be diseased. So depending on the case, we'll see where we put one of that. But again, look at this patient. This is 33 years old female, and it's just 3 days of chest pain. And this is somewhat young. It's like me here, and then I have chest pain. And as we have alluded here one day, that when young patient present with a serious thing, you think of some things. Maybe this related to behaviors, bad behaviors like maybe sexual behaviors or drugs, or bad genes. They've inherited bad genes from their parents that is making them to have a serious disease. Or lastly, it's just bad luck that I'm having a MI. It's very bad luck, or a PE at this age. So I think, David, we're going to hear the HPI and put our thoughts based on what is coming up. Thank you.
Thank you. I think that's it's already an amazing start, and I believe people are taking note. I have my notepad here and I'm writing stuff down. So going to the HPI, this patient presented with a sudden onset of central chest pain, sharp with the feeling of chest tightness, and this was severe, uh, a grade of 8 on a scale of 1 to 10, and it was radiating to the left arm and back. It was persistent, progressively worsening, initially mild, but became severe by day 3. It was not relieved by rest, posture changes, or medications. It was associated with a shortness of breath on exertion, but no difficulty in breathing or lying flat or a hunger at night. Uh, she reported awareness of heartbeat, which was described as fast and regular. She reported generalized fatigue, um, profuse sweating, nausea, and vomiting, which amounted to 5 episodes, which are non-projectile and not blood-stained. She denies fever, cough, heartburn, painful, difficult swallowing, no lower limb swelling or syncope, no heat or cold intolerance, no illicit drug use, sudden death in the family, recent major grief or stressful event encounter, no trauma, recent surgery, or prolonged immobilization. But 3 hours prior to onset of these symptoms, she reported binge drinking. So this patient was seen during the holiday season. It was around Christmas, the end of year seasons. So she was out with friends, actually traveled a long distance to Zanzibar, where she was having fun with friends. So I reported drinking prior to onset of these symptoms. And that is the end of the HPI. So any thoughts up to there, Joseph?
Yeah, thank you very much. That's a very nice HPI. Well taken. So, from all the stories that I've heard you're saying, one thing tops everything here, and that is that the patient is also having SOB, right? So we have chest pain as a main complaint, sudden onset in a young patient, and then we are told that they also have SOB. And when you have SOB, 90% of the time, this disease should sit either in the lungs or in the cardiac. So at the end, I believe probably we are dealing of pain that is coming either from the cardiac or from the pulmonary system. Then if we go into the cardiac, things that can cause both chest pain and shortness of breath can sit anywhere when you traverse these structures of the heart. So if I have pericarditis, for example, pericarditis can leak fluid into the pericardial space, cause pericardial effusion with a tamponade physiology, and I will have DIB at the end. So chest pain and DIB. If I have a disease of the myocardium, let's say I'm having things like hypertrophic obstructive cardiomyopathy, HOCM, I can have chest pain and DIB. But again, if I go inside and look at things like the valves that they're presenting with a valvular disease, less likely to cause chest pain that is acute in onset unless there is a rupture of those valves. But I don't think it should have been a very acute onset of disease like this. But again, if I look at the lungs, without thinking of anything, you have to think of a PE in this patient. Very important, because here we are discussing, I'm having an advantage that David is presenting to me. But if I am sitting at the emergency department, I have a patient like this, I wouldn't just sit and think. There are things that in the first minute that I'm thinking this patient, I've already ordered them, and they include the chest X-ray, and ECG, and troponin. So here I'll catch some things, and if these are okay, I can sit back and relax and start thinking about what's happening in this patient. But let's say, let's take this patient that the chest pain and the SOB of acute onset, they are coming from the cardiac, and I've said one of the places that can be coming is the muscles. And can you hear me, David?
Yes, I can hear you, Joseph.
Yeah, okay, sure. So And I said one of the places that they can be coming out is the muscle, and the muscles are supplied by the coronaries. So, is there a chance this patient is having an ACEs? Less likely, but possible. Adding on the history that this patient was binging a high alcoholic beverage. So, without even going further, I started thinking of something here. Um, um, uh, am I, like blocked coronaries? Like I said, it's called an. I think it's called something like non-obstructive coronary obstruction. No, sorry, that can't be. Like coronary, yes, coronary spasm. This I was looking for this coronary spasm. So I've heard some cases like this. Some young guys are drinking very high alcohol beverages, and they have alcohol. They have coronary spasm, and they present with chest pain. It's everything like an MI. You do an you look at their coronaries, and there is nothing there. So I'll be putting in mind that, but again, I will never go away from these eight causes and start thinking about other things until you give me the probably the labs or the investigations that I need, that these are not there. But right now, I'm still thinking highly likely this chest pain is coming from the lungs or the cardiac. Then the cardiac, based on the history that he was binging on alcohol, coronary vasospasm is up there, but something else is possible. Or maybe you telling me this patient later is maybe known to have connective tissue disease. I say, okay, if they have connective tissue disease, then I should think of they are having a tear in the aorta probably. So more history. I think you're muted.
Thank you for those thoughts on the HPI. So we proceed to the review of systems, which was unremarkable. Except I think for the GI, I should say I did not include it here, but this patient has been having uh, recurrent epigastric pain, and she was diagnosed with gastritis and later on treated for H. pylori infection. That was a few years back. But apart from that, the review of systems was unremarkable. On past medical history, this is a patient who was diagnosed with hypertension 1 year prior to presentation, and she's on telmisartan 80 milligrams with hydrochlorothiazide 12.5, amlodipine 10 milligrams, but the blood pressure is poorly controlled. So the blood pressures are ranging uh, in 140 something over or 150s, the diastolic more than 90 to 100, in those ranges. Um, she's also a known patient with epilepsy. Since childhood, she's on carbamazepine and phenytoin BD doses, and the last fit was 3 years prior to presentation. And she had a laparotomy 2 years prior due to an ectopic pregnancy. On obstetric and gynecologic history, she's para one living one. So the plus one was the ectopic pregnancy, and she is on combined oral contraceptives for the past 2 years. On family and social history, she's married, works as a marketing officer. She drinks more than 14 units per week, and she prefers whiskey and vodka. She's a lifetime non-smoker. There is a positive family history of hypertension in the mother. So those are the components of the history. Any thoughts, Joseph?
Yeah. So can I see? I think there was some information from the first slide there that you started presenting this time around.
Or the review systems?
Yeah. Next. Yeah. So the history of hypertension at 33 years old, it can never go without being discussed because Is among the risk factors of hypertension is age, and as we age, we're more likely to have hypertension. That you see me in my age 50 or 60, say, okay, hypertension probably 90-95% essential hypertension. But when I have hypertension at this age, myself, I'll start thinking what is happening. Like, is it secondary hypertension? So I'll do some diligence to find out whether I have another disease that is causing this hypertension. And when we talk about secondary hypertension, talk about other diseases that can bring them up, and these include maybe endocrine diseases like hyperthyroidism, or maybe hyperaldosteronism, or Cushing diseases. These can cause hypertension, but can have other diseases like diseases of the kidney, or structural diseases of big arteries coming out of the heart that can cause this hypertension. So I'll put that on my backpack and saying, okay, why is she having hypertension at this young age? Like, she was 32 and she was diagnosed, and then today she's presenting with this chest pain. But having hypertension itself is a risk factor for some diseases that we talked about that can cause this severe chest pain of rated at 8, and a DIB. To give just an example, it's a risk factor, for example, of having a myocardial infarction, right? So it's very possible. So I put this aside, but it's very important. I'll be remembering it. I can't make a connection between epilepsy now and the drug that she's using, plus that she's presenting with chest pain today. I don't know. Maybe we'll see if there is any. Next slide.
Okay.
Okay. Yeah. So COC, I mentioned PE there, risk factor for hypercoagulability. COC, they're there, so they are also important for me to think about them. And next slide. Yeah, so this person is having, like we said, bad diseases, a very severe disease in young age, bad behaviors. Alcohol is one of them, and she drinks like 14 units per week, and this is whiskey and vodka, and probably maybe even these measurements are not right. If you're drinking whiskey and vodka, to exactly say how much units is very difficult, because whiskey and vodka, they have very high alcohol content, and so probably the hypertension is because of alcohol drinking, like severe alcohol drinking. You never know. And but we're told also the mother is hypertension, so maybe it's a familial hypertension that this patient is having. So next slide. Yeah, that's it.
Okay. So yes, so we go to general exam now. Or is there anything else that you'd like to discuss before we move on to physical exam?
No.
Okay, so on general exam, this patient on general exam, this patient has and sorry, I'll take you back to the review of systems. I think I missed some things there that I did not mention. That on the genitourinary system, I think nothing was significant. ENT, okay, musculoskeletal, CNS, I said it was all unremarkable. I forgot of mentioning that this patient was diagnosed with hypertension after presenting with headaches, which were episodic and pounding.
Okay.
So I just remembered this and thought I should not go on without correcting myself. So the review systems was not completely unremarkable. She presented with some headaches. And now maybe any thoughts before we go to the physical exam, or should we just proceed?
Yeah, so headaches, they're important. I sit in clinics, and patients will come to me and maybe they have a headache, uh, and then their blood pressure is high, and it's so easy for them and maybe for a provider to say you have a headache because of hypertension. But we know that's not true. It can be true in some case, some very rare instances, very high blood pressures. But again, blood pressure should be like asymptomatic. Someone is having blood pressure, we give them medication because we want to prevent them from the risk of succumbing life-threatening diseases later in life, but not at the moment. So this blood pressure, these headaches, I don't think they're related to this blood pressure, whatever whether they think of it or a doctor is thinking of it. So I'll take it aside and think about it. But I think this is a pounding headache, and the approach of headache is to think of it: is it primary or secondary? So if it's something for a year, it's more likely to be a primary headache, but not necessarily. I've seen cases, I've read about cases of a very slowly growing tumor, for example, which present for years, and some everyone thinks it's a primary headache, but later on it's a secondary headache. So probably this patient, being a female, pounding headache, if we say they're primary, we think of things like migraine, for example, which is pounding headache, or other primary headaches like tension headaches and others. So I can't really now connect it with the other presentation, but I'll keep it aside and listening. Probably it's a secondary headache because of something else, but we'll be told later.
Okay, so we go on to general exam. The patient was conscious, restless, sweating. She was a febrile, not pale, not jaundiced. There was no anterior neck swelling, no peripheral lymphadenopathy, and no lower limb edema. The blood pressure was 183 over 115 millimeters of mercury, pulse rate of 108, respiratory rate of 18, and SpO2, she was setting 98 on room air. The temperature was 36.8, and BMI 31.2. On systemic exam, we started with cardiovascular exam. She had warm extremities, sweating. The pulse rate was 108. It was regular, good volume, non-collapsing, and synchronous with other peripheral pulses. There was no raised JVP, no precordial hyperactivity, no heaves of wheels. Apex beat was at the fifth intercostal space on the left mid-clavicular line. S1, S2 were ahead, no murmurs, no pericardial friction rub. On respiratory exam was normal. Abdominal exam, she had a midline incision scar from the laparotomy that she had. She had epigastric tenderness. Neuro exam and musculoskeletal exam were normal.
Yeah, thank you. So, as we have been told, this patient is having hypertension. The blood pressure is here severely elevated, but she's in pain. You know? A pain of 8 out of 10 can make you from normotensive to hypertensive at that moment, even if you're not hypertensive. So, it's not surprising. Um, the tachycardia plus other symptoms that this patient is having, like restless and sweating, might just reflect sympathetic drive is going up high, because chest pain is among very scary presentation to have, for anyone, even here, right? So I will say, because of sympathetic drive, she's presenting with a raised uh, heart rate. She's sweating and she's restless, and the blood pressure is leading up extremely high. Next.
Okay, next was cardiovascular exam.
Yeah, sure. So, okay, very good. So when you say there is no raised JVP, might be easy for someone to say, okay, no raised JVP, so she's not congested from cardiac causes. But that's not true. Physical exam or physical exam, if you see something, you be serious about it, that this thing is there, I should explain why is it here. But if it's not there, it doesn't mean the disease is not there. So maybe there is no JPP, but we need an echo at the end to tell us whether there are There are features of the cardiac is failing or not. Um, Again, so yes, you're telling me the the apex is perpetuated at the fifth intercostal space. And then there's 1 and 2 ahead, then there is no mama, no pericardial friction rub. Okay, fair, but I can say still nothing much is coming here that is telling me where to head on. And without wasting time, I'll head on and get some labs.
Okay. On these other systems, do you have anything to discuss here?
Yeah. So very important thing every respiratory exam. Patient with SOB, chest pain, and a and a silent chest. Then you expect SOB, you should hear crackles, and there is nothing there. When I see something like this, I put a PE up there above everything else because this happened. This is the thing that happened. Other things that you told me earlier that she was known to have gastric pain, and now we have gastric tenderness. So if you approach pain at a certain area of the abdomen, the approach is to think of what is sitting there. For example, this patient is having epigastric tenderness, and you think what sits in the epigastric region. So one is the stomach itself, from gastric ulcer to gastritis. And another thing that can also sit at that point and then cause epigastric tenderness is the pancreas. So patient with pancreatitis, for example, they hear of epigastric tenderness, but this patient shows nothing that can tell me this is having a pancreatitis. Like she's not vomiting, and we're not being told that. But um, something else is, you know, that region is also the border between the chest and the abdomen. So I've seen not once or twice patients with chest pathologies, they have abdominal presentation, or patients with abdominal presentation and they have chest presentations. It's not unusual, like to see maybe a diabetic patient coming to you, they say they're having abdominal pain and DIB. It's okay to think of an MI because maybe it's the pain coming from the chest. Apart from that, I think I have nothing else. Yeah.
Okay. So we proceed to labs. Here is a combination of several labs because I have a number, so I pile them together. We have the CBC there. We have creatinine, BUN electrolytes, and other minerals. So I think you can just look at them, and if you see anything striking, you can discuss it.
Yeah. I think all these are normal, right?
Yes. So nothing crazy here. They all normal.
Yeah. So other labs, I'm not surprised.
Okay. We also have a thyroid panel, lipid profile, as well as serologies.
Which are also normal, right?
Yeah.
Okay. Yeah. So it was good to rule out thyroid diseases by having a TSH that is normal. So we know this patient is not hyperthyroid, doesn't have hyperthyroidism, which would have maybe explained her hypertension. But that's okay. Yeah, some more labs probably. Good. Yeah. So yeah. So this machine is troponin. How much is it? The upper limit?
Yeah, I believe it's 0.4.
Uh huh. Good. So, as I said initially, I see this patient. If I'm at the emergency, I must get three things: troponin, chest X-ray, EKG, and here we're given a troponin of 6. This is super high. And let me take this time and share maybe my approach to troponin. So why do you have uh, elevated troponin in your blood? And this is a it's a troponin I, the so-called, I think, David, high intensity troponin, right? That's what we have in this country nowadays. I think HS troponin, right, David?
Yes, high sensitivity.
Yeah, so it's HS, high sensitivity. So high sensitivity meaning that previously they had measures of troponin. If you read the history of medicine, they even use TSH at one point to measure cardiac as a cardiac marker, but now not. So we have a high sensitivity troponin, which means when you see it in blood, it's coming from the myocardium. It means the myocardium is leaking troponin. So your question will be, why is that happening? Why is the myocardium leaking out troponin? So the myocardium is crying because it has been injured. And the injured of myocardium, I think I can put them in in two or three groups. Let me see if I remember them all. So one is when you have a supply issue, like the myocardium doesn't get blood. And on the other hand, is when you have a demand issue. Like the myocardium, the blood is flowing well, but the myocardium requires a lot of blood and the heart cannot give it to it. So if we start with the supply issue, we all know acute coronary syndrome, and another one is the coronary disease with non-obstructive coronaries. I think there is a word that I'm forgetting, but that was alluding to the vasospasm, the coronary vasospasm. So that is the supply issue. And in this patient who was binging, 33 years old, hypertension for 1 year, probably the vasospasm is up there than the obstructive coronaries. But what I know is the troponin never goes this high in vasospasm. It can go somewhat high. I've seen one patient with this thing, and it doesn't go this high. So there is a gap there. So if I go on the other hand, and probably think of a demand issue. The cardiac muscle wants more and more blood. The coronaries cannot give it what it wants. You think of other diseases, and this include, for example, diseases like any disease that causes severe tachycardia. So if you have severe tachycardia, the cardiac muscles are working so hard. Like patients with thyrotoxicosis, they will present with tachycardia of maybe 130. You do their troponins, usually it's high. So that's the reason. And then a very severe, but so I think this is not the case here because the tachycardia was just 108 and we can explain it away by saying it's just a sympathetic drive. But a severe hypertension makes the heart tries to pump by using a lot of force and then it leaks out the troponin. But again, it can't be this 6, like this is so high. And so another diseases that I could think of here that the cardiac muscles wants more and more blood, the heart cannot give it. Yeah, so AS, yeah, AS. So AS, yeah, I think yes, AS because aortic stenosis, you cannot, the blood is not going out of the heart. Enough blood is not going out of the heart, so you are not giving the coronaries enough, so troponin goes up. And another, yes, pulmonary embolism. Pulmonary embolism is also there is a demand issue there. The cardiac muscles wants more than it cannot get. Yeah, I think there are others that I might be forgetting, and So there is a another there is another category that I would say it's others. Why I know that? Because, for example, diseases like perimyocarditis, they also have elevated troponins, but I've not mentioned them in those two categories. So there must be another group that is called others, and I think myocardial injury, which includes things like perimyocarditis or myocarditis alone, it can cause it. Another cause, so yeah, patient with Takotsubo cardiomyopathy also will present with elevated troponin. So I will see other things around especially in this slide, and try to put where this patient lies. For example, a CRP of 74 tells me this patient is inflamed. There is something inflaming this patient. And what is it? So when we think of, inflammation, mainly we think of three things, as David usually says here: infection, autoimmunity, malignancy. I've never heard anything in this patient that suggests there is an infection anywhere. Major sites of infection include genitourinary system, the GI, the respiratory system. This patient doesn't cough, probably. There's no fever. There is no dysuria, diarrhea, or whatever. So these usual sites of infection, they are not, probably they're not there. But if I say malignancy, that is even further down, because a 3 days history is so unlikely that they have a 3 days history and you think of a malignancy. And even if you think of malignancy, where is the malignancy? It will be difficult for you. How about autoimmunity? Okay, being a female, again, autoimmunity is not something that will present abruptly like this. So autoimmunity, malignancy, less likely. Probably still there is an infection, but an unusual infection, right? And I've talked about, they have troponins of very high troponins, super high of 6. And then I'm thinking they might be having a myocarditis. So is it an infection of the myocardium, or is it a post, like an inflammatory cause of the myocardium? Because if you think of it, they're usually not known. If you read about myocarditis, you find out the literature saying, oh, it is thought that after they had a viral infection, then they have a post-viral infectious myocarditis, something like that. So maybe we're in that category of infection, but we cannot really pinpoint the place that is infected, or it is a post-infectious issue. So having in my mind a perimyocarditis or myocarditis, because the myocardium have to be involved with this troponin, and this CRP will be explained by that. AST, as I've told you, in history back then, they used AST as the marker of cardiac injury. So 58, not so much. I'm not surprised. So it might be coming again from the cardiac muscles. That's why we are seeing other things like ALT, ALP, not elevated. But a GGT of 2 to 6, this will be difficult for me to explain, because I'm seeing because for me, the work of a GGT is to try to localize the ALP. But here David is telling me the ALP is quietly normal. And then the GGT is 226, very serious, has to be explained. And if I explain it, I'll say it have to be coming from the liver. But where exactly from the liver? Is it from the liver cells, or is it from the cholangium? Yeah, so maybe one way to say is this patient is having a disease of the myocardium. The disease of the myocardium is causing them not to pump blood as usual. And then at this moment, they're congested. That's why we are seeing them having shortness of breath and because they are congested, maybe they are congested even in their liver. That's why you're seeing a GGT. That's one point that I can explain. I'm not seeing any other way. And down here, the D dimer is 471. David, this is elevated, right? And super high also. So a D dimer, it can be an inflammatory marker, but at this point, it's also telling you, hey, you need a CTPA in this patient, whatever diagnosis will be at the end, but you need to say there is no PE in this patient with this D dimer. And another is this the pancreatic enzymes that are super high, more than three times the upper limit of normal, which is according to the Atlanta criteria. Uh, Symptom is there, pain, epigastric pain, and then this enzyme is very high. You already have two. There is no sin if you say you are dealing with also an acute pancreatitis. But the presentation is so weird. For what I've seen is someone coming in, they are vomiting, abdominal pain, and they have this thing. So how do I connect all this as a person who believes in the principle of medical parsimony, that Occam's razor tries so hard to have a single unifying diagnosis to explain what you have, and at the end, if you can't at all, just separate them. We are having someone who's inflamed, their myocardium is being injured, they are leaking troponins, and they're having pancreatitis. So is this a disease that affects both organs, or one disease contributes to the effect on the other organ? I don't remember learning that I can have a cardiac disease and then it leads to an inflamed pancreas. I don't remember that. One thing I'm seeing in this patient, as you know, the most common cause of acute pancreatitis is stones. The next is alcohol. So this person binge drinking. Is it the toxin that the alcohol is showing us effect on all of these two organs? That the alcohol is a culprit here. You are having myocarditis or perimyocarditis, and then because of also that alcohol, you are having an acute pancreatitis. And probably this pancreatitis was on the back of the story, that it was the thing that it was being said, H. pylori, gastritis. Because if you read the literature on PUD, you have to have an endoscopy to say someone has a PUD, but because that is cumbersome to get, and you just diagnose them and give them PPI, they respond, you say okay. But you have to be careful. Probably this patient has somewhat low-grade chronic pancreatitis at the back, and today they've presented with acute on chronic pancreatitis. The only way we'll know that we'll have imaging. And yeah, so my thought will settle there, that probably the alcohol is a culprit here. It is causing acute pancreatitis, but again, it is also involved in the myocardium. But in the myocardium, one thing won't make sense, because as I have said, alcohol will cause coronary vasoconstriction. Coronary vasoconstriction shouldn't give me a CRP this high, 74.9. So yeah, maybe I'll sit and wait for other things, especially the images, and see if I can connect this. But yeah, David, this is a very nice case, by the way, up to this point.
Thank you very much, Joseph. I think that's um, those are that is very well thought. I saw we have a number of colleagues who joined later. Do you mind giving them a summary of where we are so far
Yeah,
before
so
we proceed?
yeah, very nice. So we are David has been presenting to me a very nice case, by the way, of a 33-year-old female who presented with the history of 3 days chest pain associated with shortness of breath. Other symptoms included it radiated to the back, and of importance in the past medical history, she's hypertensive, diagnosed 1 year ago. She has been treated for H. pylori, gastritis, and PUD. Very important issue of family and social history is that she seems to drink excessively, and even this abdominal this chest pain started 3 days ago when she binge drinking she binge drank um, a very strong liquor, and so on exam the positive findings, she was hypertensive, restless, tachycardic. She didn't have much on the systemic exam except on the GI exam that she had epigastric tenderness. The labs, FUBA picture, not so much impressive. Creatinine urea normal. And what we are seeing here is the one that is positive. A very high troponin, CRP that's also very high, and AST is very high, GGT, and the pancreatic enzyme, they are more than 3 times of the upper limit of normal.
Okay, so we proceed. I still have a number of things. We've already had some thoughts there. So one of the things you wanted ECGs. I have a number of them here. So if you see anything,
Yeah, so ECGs can be cumbersome for people like me and most of you guys here who don't see ECG on a daily basis. We're not cardiologists, but you hear the story, and you know what we want to find out on the ECG. So if you want to go one by one, saying okay, rate rhythm, that will be take your time. The only thing you should ask this patient is there ST elevation or not. And then if you finish that, you can go with the other stuff. So if I look at this patient, the lead one there, I see there is ST depression, a little bit of it, and then if you see a lead, you also read the other reads that are related on that particular segment of the heart. For example, so one will be related to others. This is the lateral wall, which include one AVL, 6 and 5. And so I look at one, I see yes, there is somewhat depression or ST depression. So I go and look at the 5 and 6 AVL. Yes, I see it on V5 and V6 also, but not in VL, in AVL. So there is a ST depression in the lateral wall, of importance because I'm finding out whether there is a ST elevation. So ST depression can reflect ST elevation in some other leads, and can I remember them? Yes. So the inferior wall, the lateral wall reflects the inferior wall. The inferior wall is 2-3 AVF, and I look at 2-3 AVF. I also see depression again, like two there is ST depression, three I don't see it. The AVF slightly there is also slightly ST depression. So other leads. Yeah, so I'm seeing ST depression, I can say, on leads 1, V5, V6, 2, and AVF. Uh, Other important things that I will be looking here include the T's, but I think the T's, they are fine. Yeah, maybe, I don't know your read from there, David. So mine is there is ST depression, which a number of differential diagnoses there, but top notch there, you think maybe an ischemia of the myocardium, but other DDX can exist.
Okay, we also have another one because remember this presentation was for like 3 days, and then she was referred to a referral center where some doctors in the audience saw the patient. So here was another one which was done after the chest pain did not subside. So do you see anything?
Yeah. So again, lead one still depression, quite more significant than the initial one. So I also go on. The other one was AVL. There is depression again. The 5v6, yes, depression. So that all the lateral wall, there is depression, but their T wave still up there. And so yes, lead two still there is depression. This lead three, no, I don't think if there is anything on lead three, unless I'm not seeing well. But yeah, another thing is the 1v2. Yeah, I'm only seeing it's the depression in the lateral wall and in the inferior wall.
Okay, so yes, the reading almost the same. It's I mean, apart from especially, so another thing was about the tachycardia, slight tachycardia, and then similar changes as the ones you've reported. So, any thoughts so far, or anything else that you'd love to do at this point?
Ah, so you know, in diagnostic reasoning, first of all, why is diagnostic reasoning important? It's important because you got to get the diseases as early as possible. You have to have your thinking. And to arrive at a diagnosis correctly, you have to pose the correct problem. If you miss to correct to ask the correct question, you're likely going to answer the wrong question. So I am lacking. I understand that what I am lacking here, I have seen the problems. This is the patient that her myocardium has been injured, she's inflamed, and I've thought it has to be a myocarditis plus or minus a perimyocarditis. Both are true. But the 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 pancreas is also injured. There is a symptom, typical abdominal pain with pancreatic enzymes elevated 3 times the upper limit of normal. My problem here is what is happening. Is the alcohol the culprit that is causing both of these? Or there is a disease that I don't know, or maybe I know but I don't have enough information that it can cause the other one. I need imaging in this patient. So if I have everything, for example, to first of all, you need an echo. By the way, that is the most important thing. But again, you need to start with. You need an ultrasound of the abdomen. It can show you some things, and depending on what you see in those images, it can lead you to need another imaging. For example, for the pancreas, you need a CT abdomen. For the cardiac, you need a CMR, for example. And yeah, so at that point, now you'll be sure that you have these problems, and you try to figure out what is happening. Maybe they're not related. This patient was just having her own pancreatitis even before, and just today she's having a myocarditis. That's why she's presenting here. So I need imaging.
Okay, so thank you again for the superb discussion, and I echo the point that you mentioned. So to get a correct diagnosis, you need to ask the right questions. I remember a CP Solve Rabbi once said, I think that the hardest thing about clinical problem solving is not solving the problem, but knowing which problem to solve. So I think everyone today appreciates how clinical reasoning is not always roses. So sometimes, sometimes actually many times, we find ourselves in crossroads, not knowing what is going on. And I believe that raises our morale in shaping our clinical problem solving skills every day. And Joseph is doing a good job so far. So you wanted some imaging. So echo was done. I do not have all the images, but here is one. I'm not sure if you are familiar with this one.
No, no.
It's one of the technologies. If you know anything about it, you can say.
How can I know this, David? I don't know anything about this. I see maps.
Okay, so this one I'll just of course I myself I've not familiarized myself with it, but it's one of the newer technologies in Echo. It's called speckle tracking,
Okay.
and so this shows the regions. So what you see, I think just a few things to know. You see the at the center there, we want all the color to be that way. So if you see anything blue or with the color in this anterior wall, the lateral wall, the posterior wall, that is not what is supposed to be seen. So it's this one shows global longitudinal strain. So basically, that means the areas that you see are not as red. I'm not sure if this is red or orange, but the areas like the blue ones means that they are dyskinetic to akinetic. So basically, there are regional motion abnormalities, and the conclusion on echo was that the walls that I mentioned, especially the base, the lateral and the posterior base were dyskinetic, and the ejection fraction was mildly reduced. So those were the main findings that were reported on that echo. So maybe we'll just proceed. CAG was done, which was normal, and this was the ECG post CAG. So if you have anything, and this is where you commit to a diagnosis before I reveal what went on.
Hmm. Can I start that ECG again?
Okay, this one.
Yeah,
So that was post CAG, and CAG was reported to be normal.
yeah.
So no obstruction was found in all coronary, in all epicardial vessels.
Okay. Um, so what we are seeing here is inverted T, right, on the one, the AVL, V5, V6, then before, the ones which had an ischemia before. Okay. Yeah. So let's go back to that image that I don't know and see. I want to see that the walls. So yeah. So it means here the anterior wall, the lateral wall, and the in the inferior wall, they were. You mean they were akinetic, right?
Yes, so basically, most of them were dyskinetic, and especially the blue ones is almost akinetic.
Yeah. So this is helpful because you have put in a needle and examined the coronaries of this patient. They are not blocked. So do they have what we call, because this is the regional, this is regional, and then you put an angio and you see that they are not blocked. I said there is a supply and demand issue. So maybe should I move myself from the inflammation and wherever, which will be difficult, and think this is a supply, is a demand issue. No, it's a supply issue, but the supply is not because of obstruction that we can see. I think it's called MI with non-obstructive coronaries, MINOCA. Is this the case? Because otherwise, can you have myocarditis and just okay? Am I missing? So David, all the walls are affected. All the walls, like globally affected.
Oh, so it's the base, mostly the anterior and the lateral, and part of the posterior, not all of them.
Not all of them.
Yes.
Yeah. Okay. Let me come again. So I have a number of diagnoses in my mind. One, it can be a minoca, that is a myo with non-obstructive coronaries because of vasospasm, because of that binging of that alcohol. I don't think if that will give you an ESR CRP of 40 something. I don't think so. Another would be a Takotsubo cardiomyopathy. If I had an echo and see if there was apical ballooning, I would have thought of that. But again, the history doesn't tally. If you hear the case of Takotsubo cardiomyopathy, you have this patient that there is something prior, and usually it's there. Usually it's there that there is a stressful event, and then they go into a Takotsubo cardiomyopathy. So I put that down there. On my thing that I was thinking before, is this a myocarditis, post-infectious, or an idiopathic myocarditis? I don't think if in the myocarditis I expect first of all EF usually more lower than this 48, but all the walls could have been affected, I think. And the EKG after angio like went back to show that this patient had ischemia before and it has resolved. What is this? I think I put David number one, the Minoca, the MI with non-occlusive coronaries vasospasm. Um, I know that cannot. Maybe you tell me, but I know that cannot explain the CRP. I'll try hard and find out what explains the CRP. But sometimes CRP, Sarah, they just tell you patient is sick or not sick, which the patient is sick, and her her pancreatitis, I can give a best guess. Maybe it was there. She's stressed now, or she drank too much, and then she went into pancreatitis. So alcohol may be the culprit of both these vasospasm, coronary vasospasm, and pancreatitis. Yeah, you tell me.
Anything that you'd like for clarification, please welcome. Today has been a bit of a long case, but I believe it's very interesting for everyone. Michael, karibu.
Asante
Hello.
Sifa. So on the echo, you please report on chambers because the first EKG and second EKG showed some sort of people pulmonale. So I was expecting to hear about whether we have a right atrial enlargement or left atrial enlargement, and then link it up with the alcohol and say whether it's we have other chamber enlargement. Probably thinking of a cardiomyopathy, the other.
Hello, David.
Okay, okay, Joseph, you're back. So yes, Michael, thank you for the good question. So at least on the ECG, I mean on the echo report, they did not report on any chamber enlargement. So all the chambers were normal. All that was reported was those regional motion abnormalities. So okay, Joseph, you can pick up from where you ended.
Yeah, where did I end? Because my phone heated up.
Okay, so you were discussing, you are finding the connection. You said probably Minoka would not give this high CRP, so you
Yeah,
are trying to find out what exactly could explain all these findings.
yeah, because um, can you hear me?
Loud and clear.
Yeah, good. Because sometimes we find that one thing that blocks you from reaching a diagnosis, and you say if I remove this, will it explain everything? Yeah. So the CRP, I think of these inflammatory markers, CRP as they mean someone is sick versus not sick sometimes. So yes, this guy is sick. Maybe that's why the CRP is up there. Uh, I'll put my coin on MI with non-obstructive coroners versus spasm because of binge drinking, and the alcohol also can be causing acute pancreatitis in this patient. Maybe I should hear from you.
Okay, so thank you. So what you went through, and I believe everyone has noticed how clinical problem solving can sometimes be a very grueling task. You have findings in the history, you are suspecting some things, and then uh, the whole thing takes an unexpected turn. So, for example, for this patient, a 33 years old female, acute chest pain, and then you do troponins, you have all things that are suggestive of an acute coronary syndrome, but then the ECGs are not very supportive. You do coronary angiography, which turns out to be completely normal. So uh, that's uh, that is exactly what even the attending team went through. So this patient was initially seen in Zanzibar, as I told you. She went there for vacation from another country, and then she developed the sudden chest pain, and then they attended her there. Initially, they thought about acute coronary syndrome. So she was treated medically initially with no response. So they had to take an air ambulance and refer her to JKCI, where they did coronary angiography, which turned out to be normal. So people sat back and asked themselves, what is going on? What exactly is going on with this patient? So all the other results that you see, and I can tell you that I myself was not part of the attending team. So Dr. Shabir, I believe, who is in the audience, and Dr. Adija saw this patient, and they presented her for the grand round. I did not take part in her management, but I myself do not have explanation for a number of things. What is the cause of the GGT elevation? What is the cause of the CRP? I do not have a clear explanation up to this point. So I think a good job on your side, Joseph, so far. Uh, and we'll see maybe later on I'll discuss some things on maybe what could have been done differently. So you said you'd need imaging starting with abdominal ultrasound. And what was striking for the abdominal ultrasound is that there were features which were suspicious for a hepatic lesion, and they recommended a CT abdomen. Now, CT abdomen was done, and as you can see on my left, there is a discrete mass. There is a discrete mass on the liver there, which seems not to be very much attached to it, and it was taking up contrast very avidly. I believe you can see my cursor. So another view uh, describes this or delineates the mass very clearly. You can see that this mass is sitting on top of the kidney, on top of the right kidney of this patient. I believe you can see that, Joseph, and everyone else.
Yeah.
So we have the right kidney here, and we see this mass. It's a huge mass on top of the right kidney. On top of the left kidney, of course, we see the suprarenal gland, but the one on the right is bigger than the one on the left. So there's a number of things that were not done due to limitations in our setting. One of them being uh, plasma or urinary catecholamines and metanephrines. Those ones were not done. But then with this mass and the clinical presentation of the patient, pheochromocytoma also was thought to be the most likely diagnosis, explaining the uncontrolled secondary hypertension. And I've put some question marks on the last two diagnoses because uh, maybe we cannot say 100% that they are present, but of course you were discussing about MINOCA or INOCA, that is myocardial infarction with non-obstructive coronary arteries or ischemia with non-obstructive coronary artery. So of course, this patient had features of ischemia or infarction, elevated troponin, but also the ECGs had ischemic features, and then there are regional motion abnormalities. So on my reading, one of the things, of course, uh, pheochromocytoma can also present with a stress cardiomyopathy, Takasubo-like, which is also a possibility in this patient. And then the pancreatic enzymes were elevated. And with one of them, I believe, so one of them was about 2.8 times the upper limit of normal, but another was 4 times. So at least one was more than 3 times the upper limit of normal. The patient had epigastric pain, and Joseph, if you could recall from the history, this patient also had some 5 episodes of vomiting. So at least 2 out of the 3 which are needed to make a diagnosis of acute pancreatitis were present, which is abdominal pain, which is kind of typical for acute pancreatitis, epigastric pain radiating to the back.
Yeah.
Although this patient's pain was also, the chest pain was radiating to the arm, but also to the back. But on imaging, the CT that was done reported the pancreas to be normal. So there was no pancreatic edema, no peripancreatic collection, or any features of necrosis. So now rewinding, could the diagnosis of pheochromocytoma, for example, have come out earlier on? Probably, although this was very difficult. Why? Because this patient presented, was diagnosed with hypertension 1 year prior to the onset of symptoms of this chest pain. And this hypertension was, we could say it was resistant, because the patient reported a good adherence to 3 antihypertensive medications, because that was telmisartan, losartan, as well as hydrochlorothiazide, but the blood pressures were not well controlled. And again, you alluded to this, Joseph, that we are dealing with a 33 years old female with hypertension. So you actually went into a brief discussion of secondary hypertension. So the hypertension was uncontrolled. Maybe there's one thing in the associated symptoms that you did not discuss. This patient reported awareness of heartbeat, which of course in the setting of chest pain, we could think of a sympathetic overdrive explaining the palpitations. But it seems this patient had been having these palpitations for quite some time. And then I corrected myself and went back to the review of systems, that the patient had episodes of pounding headaches for the past 1 year. So basically, we see that this patient is having uncontrolled hypertension. The patient is having palpitations. The patient is also having, has been having recurrent headaches. And then when we went to physical examination, this patient was sweating. Although now, of course, if you see any patient with even with acute coronary syndromes, even patients with pulmonary edema would be diaphoretic. So I think if we say that the sweating would point us in the direction of pheochromocytoma, maybe that would be hindsight bias, but maybe it will tell us something that we are probably dealing with this. So that was the final diagnosis. We think it's pheochromocytoma because of the imaging, but of course, in order to make that diagnosis, we definitely needed biochemical confirmation, also checking the catecholamines on metanephrines, which were not available in our setting. So I have a few teaching points, um, and so I'll discuss 3 concepts just very quickly, because we are beyond time. So number 1, when to suspect a secondary hypertension, like in this patient. So when you have severe resistant hypertension, and we know the definition of resistant hypertension, if you have a patient with a recent rise or increased lability of blood pressure in a patient with previously stable values, and then age less than 30 years, this patient was 33, but then if age less than 30 in a patient with no obesity, this patient was obese with the BMI of 31.2. She had a family history, But another one now is malignant or accelerated hypertension. When you have hypertension with features of end organ damage, and it's debatable, but then acute coronary syndromes or a cardiac presentation in a patient with a markedly elevated uh, blood pressure would be taken as one feature of end organ damage. And then if you have hypertension associated with electrolyte disorders, you could think of like primary aldosteronism, and when someone has an age of onset before puberty. So this patient had at least two out of the ones that I've mentioned. And next, some causes of secondary hypertension. So there is renal vascular disease, parenchymal kidney disease, primary aldosteronism, which would present with hypertension and hypokalemia probably, sleep apnea syndrome, pheochromocytoma, which we think is the case in this patient, Cushing's syndrome, coarctation of the aorta, other endocrine causes like thyroid, which Joseph discussed, hyperparathyroidism, that is a rare one, but medications, including contraceptives, chemo agents, and some other medications. So I think for easy remembering, I think it would be good to divide these causes of secondary hypertension into organ systems like renal, uh, like vascular, where for vascular now you would have renovascular hypertension as well as coarctation, and then endocrine, where pheochromocytoma, Cushing's, thyroid as well as parathyroid will go in there. Now for pheochromocytoma, this is a catecholamine secreting tumor which arises from chromaffin cells of the adrenal medulla. You can also have similar tumors from sympathetic ganglia, and these ones are known as paragangliomas, although some other people do refer them to as extra-adrenal pheochromocytomas, but the more appropriate term is catecholamine secreting paraganglioma. So they are generally rare, occurring in 0.2% of patients with hypertension. And they can occur at any age, but the common age of onset is between the fourth and fifth decades of life. Uh, Both genders are affected equally, and most of them are sporadic, but you can have some which are familial or hereditary forms like pheochromocytoma as part of multiple endocrine neoplasia type 2, von Hippel-Lindau disease, or neurofibromatosis type 1. And symptoms are present in 50%, which means you can have half of patients who are symptomatic, and typically the symptoms are paroxysmal. And we talk about a classic triad of episodic headaches, which is present in 90%, sweating in 60 to 70, as well as tachycardia. And most patients do not have the classic triad. And sustained or paroxysmal hypertension is the most common sign, although it can be absent in 5 to 15% of patients. And less common findings are orthostatic hypotension, especially when epinephrine is the dominant catecholamine produced, and apparent symptoms of diabetes. Cardiomyopathy is also another uncommon presentation, similar to stress cardiomyopathy. So Takotsubo cardiomyopathy, which Joseph has mentioned a couple of times. So in order to make a diagnosis, it should not be the other way around. You should start with biochemical uh, evaluation and then followed by imaging. And there are differences among centers on the way to approach this, because for biochemical itself, you can either do it in the urine, where you do 24-hour urine metanephrines and catecholamines, or you can do it in the plasma. So some experts what they do is they recommend that if you have a high index of suspicion of pheochromocytoma, then you go with plasma, and if you have a low index of suspicion for pheochromocytoma, you go for urine metanephrines and catecholamines, and then it is followed by imaging, either CT or MRI, which will show a mass, commonly a suprarenal mass, which with an attenuation of more than 10 Hounsfield units. The definitive management is adrenalectomy, but preoperatively, these patients need to be kept on combined alpha and beta blockade, because if you give them beta blockers themselves, you will exacerbate their hypertension because of an opposed alpha adrenergic activity. So you should give both of them, alpha as well as beta blockers, a high sodium diet as well as volume resuscitation, because the catecholamines can also cause uh, vascular volume contraction in the intravascular compartment. So those were the teaching points that I have. Any reflections, Joseph?
Oh man, thank you very much, and thank you to the team that took care of this patient, Shabir, and the his fellow doctor, and the team at JKCI, and you for presenting this. But I have a question before reflection. So, did echo show apical ballooning?
No, echo did not report apical ballooning, so it was just the echo report that I saw reported the regional motion abnormalities that I mentioned, but no apical ballooning.
So, we still don't know. Could we say it's Minoka, or still we don't know?
Yeah, so most likely what was thought, because of the elevated troponins, uh, the most likely cause that explained that this was thought to be ischemia with non-obstructive coronary arteries.
Sure.
But again, of course, if you read Takotsubo cardiomyopathy in detail, so apical ballooning is a common finding, but it's not necessary to have apical ballooning to say this is Takotsubo.
Okay.
And as you know, one of the most reported hypothesis as to Takotsubo cardiomyopathy is when there is a catecholamine excess,
Sure.
which can be caused by a pheochromocytoma. So that's why I put those question marks there. I think we need to go and do more reading, because Takotsubo itself can also present with elevated troponins,
Sure.
regional motion abnormalities, and the presentation that we see a chest pain that is very in keeping with acute coronary syndrome. So I think either of the two could explain the chest pain and the findings that we see, either inoka or stress-induced cardiomyopathy.
Yeah, thank you very much. So, I love this forum. I've never seen Phil. I've read about Phil. And then I don't even know if I had this patient, if I could have arrived at this diagnosis. Probably because of the abdominal pain, I could have done the CT, but it would have come as an incidental. So those doctors, kudos, they're very intelligent. And even this patient, when they go home to their country, they'll think we have brains here who can come up, even if we don't have the methanephrine, for probably. We have them, maybe they just were not done. But I have this forum because, man, I cannot say, but this is very nice. I've learned a lot, I can say, although I missed the diagnosis, but this is why we are doing it. So maybe I'm going to read very deep on from Takotsubo to Minoka and then to Fio. Thank you very much. I appreciate this.
Thank you very much, Joseph. So I should say that was I should say that that was incredible work. I mean, I myself, of course, I also think so. The same thing happened to the team that was attending this patient after a normal CAG in a patient you are thinking about acute coronary syndrome came negative. Then so I think they need to be applauded for that. They did not rest
Sure.
and say, okay, your coronaries are normal, so we think you'll just be fine, go home. They investigated this patient further, and the diagnosis was revealed for this patient who had been treated for hypertension, not responding to medications for 1 year. So at least the cause has been found. So I think I should again applaud the doctors, including Shabir, who attended this patient for the incredible work that they did, and you, Joseph, for the incredible discussion, because I think I've filled a number of pages here, taking some notes from your approach to a number of problems. So I think, honestly speaking, I also think I would have missed the diagnosis, because this patient had a mirrors. So you are discussing chest pain, you see elevated pancreatic enzymes, you see an elevated CRP, elevated cholestatic markers, apparently. So I think that was very incredible work on your part. So thank you very much for the discussion and for teaching us. And so if anyone has any comments, just very briefly before we close this session, you are very much welcome. Yes, I see the crowd is silent. I saw a lot of clapping, so that is for you, Joseph. No, I've also seen some messages in the chat. Uh, so thank you very much for the comments and for being here. So this is the reason we started this forum. We need to keep learning, because as we see, medicine keeps humbling us, keeps teaching us every day. So we want this to go on. So thank you very much, everyone, for joining. The crowd was huge today, and so we believe people will be attending without reminders. And I saw that today. I sent some reminders, but by the time I was sending reminders, there were more than 15 people, I think, who had already joined, remembered by themselves. So the community is getting bigger, and we are happy to see that. And we are happy to have you around learning together. So one more time, I will insist, if you have cases, please feel free to contact us and come present a case. If you want to discuss a case, you are more than welcome. We want to learn from you. So we've learned a lot from Joseph. I've discussed some cases here. We would be very much happy to have a breath of fresh air by someone else discussing a case, in order for us to pick their brain and learn from them. So we look forward to someone discussing a case or presenting a case in the near future.
Sure.
So thank you very much, everyone, for joining. We hope to see you again next week. Have a good night.
Good night.